Hello everyone, I'm Dr. Manisha Sharma. I'm consultant pediatrician at Kanti Children's Hospital, and today we are going to review pediatrics session of CEE 2017. Let's go to the first question. So the question is, what is the most likely cause of unilateral nasal discharge in children? And the options are ethmoidal polyp, nasopharyngeal carcinoma, inverted papilloma, and the next is foreign body. So let's go to the first option, ethmoidal polyp. So ethmoidal polyp are usually bilateral, and and it is more common in adults, and the most common presenting feature will be nasal obstruction. So this rules out our first option, that is ethmoidal polyp. Now let's move to the second option, that is nasopharyngeal carcinoma. And the nasopharyngeal carcinoma, these are more common in adolescents, and the main presenting feature will be nasal obstruction. As our patient is children, so these children with unilateral nasal discharge, so this rules out our second option, that is nasopharyngeal carcinoma. Now let's move to the third option, that is inverted papilloma. It is one of the rarest nasopharyngeal carcinoma, and it is more common at around 50 years. So this also rules out our next option. So the last option is foreign body, and this one is the correct answer, and it is one of the most common cause of unilateral nasal, foul-smelling nasal discharge. Nasal discharge, and the foreign body can be organic as well as inorganic. So let's move to, so this slide sums up our answers. So ethmoidal polyp are bilateral, multiple, and common in adults and present with nasal stiffness, whereas inverted papilloma is rare with mean age of presentation 50 years. And nasopharyngeal carcinoma, these are uncommon in children less than 10 years, and these are more common in adolescents, and is usually present with lump in the neck and the nasal obstruction. And foreign body is our answer. Let's move to question number 2. Let's read out. It says, unit of 2 weeks age with a history of excessive vomiting present with the signs of severe dehydration. The ideal fluid of choice to resuscitate such a baby after the bolus is, so the options are 0.9% NaCl, normal saline at the rate of 125 to 150 mg per kg per day, ml per kg per day. The next one is half NS at the rate of 150 ml per kg per day. The third one is half NS at the rate of 125 ml per kg per day. And the fourth one is 10% DNS at the rate of 100 ml per kg per day. So before going to select the answer, let's know that let's know a little bit about fluid resuscitation in child, in neonates. So for bolus, we keep NS at the rate of 10 ml per kg. So before going to choose the fluid, let's know what is the total amount of total ml of fluid required for children. So if it's a term and preterm, so if it's a term, the first day fluid will be starting from 60 ml per kg per day, but for preterm it will be 80 ml per kg per day. So by 5th to 7th day, the total fluid requirement will reach to 150 ml per kg per day in term as well as preterm. So after that, after 7 days onward, the total fluid requirement will be 150 more ml per kg per day for the whole neonatal period. Now next thing is choice of fluid. Choice of fluid. So usually for the first 48 hours of life, the choice of fluid will be 10% dextrose. So after that, we usually use fluid with a low sodium content. Ideally, we use N/4 or N/5 plus 10% dextrose, as the ideal fluid is not in our option, so we'll choose the fluid with low sodium content. So after knowing all these details, we come up to the second option, which has fluid rate of 150 ml per kg, as our baby is 2 weeks age. So after 7 days onward, we knew that the total fluid that is required is 150 ml per kg, and the less sodium is in option B. So we'll go with the option B. So let's move to the next question. Question number 3. Make the diagnosis of a 2-week-old neonate presenting with recurrent non-bilious vomiting with constipation and loss of weight. So the question says it's a 2-week-old neonate with recurrent non-bilious vomiting with constipation and loss of weight. So the options are esophageal atresia, colidocal cyst, ileal atresia, and pyloric stenosis. So let's see the option A and C. Usually ileal and esophageal atresia, this presents early. So our patient is already 2 weeks old, so the symptoms should have presented early. So and the next thing is esophageal atresia. This usually present with frothing and excessive secretions. Whereas in patient with ileal atresia, this presents with vomiting, but the vomiting will be bilious. And our question has said that the vomiting is non-bilious. So this rules our first and third option. So let's move to the second option, that is colidocal cyst. Now colidocal cysts are the cystic dilatation of the biliary tract. So usually colidocal cyst usually present with prolonged jaundice and abdominal distension, and it doesn't present with vomiting or constipation or loss of weight. So this rules out our second option. Now, so after all this discussion, we come to a conclusion that pyloric stenosis is the correct answer. So what is pyloric stenosis? Usually pyloric stenosis is thickening of the pylorus. Usually the thickening will be more than 4 mm with increase in the pyloric length greater than 16 mm. So and this patient usually present at 3 to 6 weeks of life with symptoms of non-bilious vomiting, with constipation and loss of weight. And there is one PQ that usually comes associated with pyloric stenosis, that is what will be the ABG or what will be the electrolyte imbalance in pyloric stenosis. So usually what happens is when there is vomiting, there will be loss of H plus and Cl minus electrolytes. So as H plus will be less, there will be metabolic acidosis, alkalosis, and loss of chloride will result in hypochloremia. And as the hydrogen is lost, the kidney tries to absorb the H plus ion in favor of in exchange of K plus or potassium. So there will be hypokalemia. So in pyloric stenosis, what we get, the electrolyte imbalance, it is hypokalemic, hypochloremic, metabolic acidosis. And for the treatment, what we do, it is pyloromyotomy. So let's sum up our pyloric stenosis. So the same thing is written in the slide too. So let's move to the next question, that is question number 4, and let's read it out. 2-month-old child with jaundice and biliary atresia what is the investigation of choice in this case? So the options are MRCP, liver biopsy, CT scan, or HIDA scan. So usually what happens is MRCP and in CT scan there is lack of visibility resulting from the insufficient bile, or there is the diameter of the biliary tract are too small. So this test can be used for screening, but this can confirm the test. So, and for HIDA scan, what happens is in HIDA scan we give the dye through intravenous route, and we look for the hepatic uptake as well as its excretion into the bowel. So what happens in this biliary atresia is there will be good hepatic uptake, but as there is no as the biliary tract is deformed, so there won't be any excretion in the bowel. So it is same as MRCP and CT scan. This test can be used to rule out the disease, but it is not a confirmatory test. So the gold standard test is liver biopsy, and what we look in liver biopsy is bile duct proliferation. If there is any presence of bile blocks, is there any portal or periportal edema or fibrosis with the basic hepatic globular architecture intact. So let's move to question number 5, and let's read it out. Pregnant women having gestational diabetes mellitus delivers a baby. 24 hours postnatal, the baby develops a seizure. Bedside glucose level is within the normal limit. What is the next line of investigation to find out the cause of the seizure? So what we need to find out is the cause of the seizure. So what are the options? Serum calcium, blood glucose levels, CBC, or lumbar puncture. So it is a 24-hour child born from a woman having gestational diabetes, and he is having a seizure. So, and the question says the bedside glucose level is within normal limits. So this rules out our question option number 2. So when we are looking at option number 3 and 4, CBC and lumbar puncture, these are usually done to rule out sepsis. So in patient born by a mother with gestational diabetes, they are not at risk of sepsis. So this rules out our options C and D. So let's talk about the metabolic abnormalities in patients born. So most common abnormalities seen are hypoglycemia, hypocalcemia, and hypomagnesemia. So the right answer is so what we're gonna investigate is serum calcium. So why there is hypocalcemia? Usually what happens is usually the pathophysiology behind is there will be maternal hypomagnesemia, which will lead to low magnesium level in neonate, and this leads to functional hypoparathyroidism in neonates. So as the PTS level will decrease, this will lead to decrease in serum calcium, as PTS helps to release calcium from bone. So the answer is serum calcium level. So let's move to the next question, 6 number, and the question is, the child presented with developmental delay with protruded tongue, hypotonia, and lax abdomen. What is the most likely cause? So the options are Down syndrome, cretinism or hypothyroidism, C, malnutrition, and D, hyperthyroidism. So what happens is the patient has presentation of developmental delay, protruded tongue, hypotonia, and lax abdomen. These are all symptoms of hypothyroidism. But let's rule out other option. So first option was Down syndrome. So in Down children, we have typical dysmorphic faces like upward slant of the eyes, Mongolian eyes. So Mongolian broad nasal breeze, similarly simian crease, And there will be features of hypothyroidism also in the patient of Down syndrome, but only 2 to 7% of the patient with Down syndrome will have hypothyroidism. So if the question would be suggestive of Downs, then they would have given us dysmorphic features. So this rules out our first option. So in cases of malnutrition, there may be lax abdomen, but there won't be hypotonia, there won't be protruded tongue or developmental delay. So this rules out our option C. Similarly, in patient with hypothyroidism, the patient will have symptoms of palpitation, tachycardia, tremors, hypotonia. So this rules out our option D. So the best answer for this question is cretinism or hypothyroidism. So usually patient presents with coarse faces, open mouth, as in this patient, and protruded tongue. Similarly, umbilical hernia will also be present. Along with it, lax abdomen, developmental delay will be present. So this sums up our question number 6. So let's move to question number 7. And let's read it out. 6-year-old child with persistent deficit in social function, and he doesn't play well with peers. He also has stereotypic hand movements. And what is the most probable diagnosis in such a case? So the patient has deficit in social function, so social relationship is affected, doesn't play well with peers, he has stereotypic hand movements. So what are the options? First is autism, the second one is Rett syndrome, the third is Tourette syndrome, the fourth one is pica. So let's explain all these symptoms. So first, go to Rett syndrome. Usually Rett syndrome is a neuroregressive disorder. What happens in this is there will be progressive loss of already achieved motor skills and language. And in this patient, it hasn't suggested any of these things. So this rules out our second option. So in Tourette syndrome, what happens is there will be repetitive movement or unwanted sound that can't be easily controlled. So it is involuntary movement, and the tics are that occurs that they are usually rapid as well as random. So there is no any stereotypic restrictive behavior. So this also rules out our third option. So and pica, it is persistent ingestion of non-nutritive substance for at least 1 month, and it is inappropriate to the child development level and cultural practice. So this also rules out our option number D. So the best answer for this question will be autism. So let's talk about autism. What are the things that occurs in autism? Usually the onset occurs before 3 years of age, and there are 3 things that are affected in autism. So first one is communication. So there will be impairment of verbal as well as gestural communication. The second thing, there will be defect in social and emotional reciprocity. And the third one is the patient will have stereotypic restrictive behavior patterns. So in our patient, the patient is 6 years old, the patient has social deficits, the patient has stereotypic hand movements. So the most probable diagnosis in such case is autism. So let's move to the next question, question number 8. And it reads out, a young boy was playing game on playground in a hot climate. Later, he develops a decreased level of consciousness, confusion and lethargy. His friends on inquiry give a history that he drank an excess of water before coming to the ground. What is the most likely cause? Symptoms are due to increase in. So what happens is the patient has drank excess of water, which has led to decreased level of consciousness, confusion and lethargy. So what is the reason behind this? So as the patient has increased the fluid intake, what happens is there will be an increase in hydrostatic pressure in extracellular fluid. This leads to fluid shift from extracellular fluid to intracellular fluid as the tonicity is increased in intracellular space. So this leads to increase in intracellular volume. So this sums up our answer, and it is increase in intracellular volume. So in what case there will be extracellular hypervolemia? If the patient has taken high salt or sodium or anything, if it has taken, then there will be increased in osmotic pressure, osmotic tonicity in ECF. As a result, the fluid will be drawn from ICF to ECF. This will lead to extracellular hypervolemia. So, as in this case, the patient has drank a lot of water, which has led to increase in intracellular hypervolemia. So, the option is C. So, let's move to question number 9. A pregnant woman presented to Obs-Gynae department on serological testing is found to be positive for hepatitis B with a high IgE antigen level. Deliver the baby boy. What is the earliest step taken to the baby? So, the options are vaccination against hepatitis B only, immunoglobulin of hepatitis B only, hepatitis B vaccination with immunoglobulin, and the next option is delay vaccination for 6 months. Usually, when a baby is born to a HBsAg positive mother, what we have to do is we have to give hepatitis B vaccination along with immunoglobulin within first 12 hours of life or as soon as possible. Why? Because if you give only hepatitis vaccine, then you are giving passive immunization. So the patient may have hepatitis B by a perinatal infection. So to have active as well as passive immunization, we have to give both within first 12 hours of life, and the hepatitis vaccination, the remaining 2 doses are given at 1 and 6 months. But in Nepal, what we do is the vaccinations are given in our normal immunization, national immunization schedule. So what we do, the next thing what we have to know is when to check. When to check with So the repeat testing of HBsAg antibody and HBsAg is done at 9 to 12 months. So this sums up our question number 9. So question number 10. After a recent episode of an earthquake, the nutritional assessment of child in the community can be best assessed by options are body mass index, weight for height, weight for age, height for age. So the question is asking about the nutritional assessment in the community after a recent episode of earthquake. So the question is asking us about acute malnutrition. So, what parameter is used to assess the acute malnutrition? Usually, weight for height is used to assess acute malnutrition, whereas height for age is used to assess chronic malnutrition, and weight for age can be used for acute or chronic malnutrition, and BMI is not a reliable indicator to assess the malnutrition in children. So this sums up our answer. So the answer is weight for height. So question number 11. A child with high grade fever, poor feeding and altered sensorium has neck rigidity. On examination, you suspect the case to be meningitis, but there is no facility to perform gram staining of CSF sample. In such a setting, we give empirical antibiotic for how many days? So this is a case of meningitis, suspected case of meningitis, and we don't have a facility to perform a gram staining of CSF. In such a setting, what we're gonna do? So once we suspect it to be a meningitis, we start with an empirical antibiotic, which includes ceftriaxone plus vancomycin, and usually once the CSF culture and blood culture arrives, depending on the organism, we decide the duration of antibiotics. So if it is a if the positive organism is Streptococcus pneumoniae, we give the antibiotic for 10 to 14 days. If it is Neisseria meningitis, we give it to 5 to 7 days. If it is Haemophilus influenza, then we give for 7 to 10 days. And if it is Listeria, we usually give to 21 to 28 days. So, but in our setting, in our case, what has said is there is no facility to perform gram staining of CSF sample. So in such case, we usually give antibiotic for 10 days according to Nielsen. So usually Nielsen has stated that if you have given antibiotic prior to LP, or if we don't have any facility to perform gram staining of CSF culture, then usually give antibiotic for 7 to 10 days. So the best near about answer will be answer number B. So let's move to question number 12. So it states that 2-year female child has a history of low-grade fever and cough for 2 days during the presentation on emergency department. The child has stridor and he is in respiratory distress, but he is not toxic. What is the initial step to be taken in this case? So the options are perform a chest X-ray, give a stat dose of antibiotic, intubate the child, or maintain correct position and give the oxygen. So in this minute, there is a 2-year child with a history of low-grade fever and cough for 2 days. And the patient has stridor, is in respiratory distress, but is not toxic. So this history is suggestive of croup, as the patient has a stridor as well as low-grade fever. So, and he is not toxic. So in croup, what we do is first we'll do emergency management, that is maintain correct posture, give oxygen. Okay, we'll assess the airway breathing circulation. Okay, then the main treatment will be dexamethasone at the dose of 0.15 to 0.6 mg per kg stat dose. So stat dose of dexamethasone will help improvement in the croup. So while looking at the options, so X-ray we will be doing it, but the first step we have to stabilize the patient. So option A is not the correct answer. Give a stat dose of antibiotic. We usually don't give antibiotic in case of croup. We give a steroid. So this rules out our second option. Third, intubate. The patient may have respiratory distress. The patient is not toxic, so we don't have to intubate the case. Before intubating the case, we have to do the respiratory distress score. If it is greater than 7, then only we are going to intubate the case. So this child doesn't need intubation. So this rules out our third option. The last option is maintain correct position and give oxygen. So this is the best answer for this case. So first what we do is we maintain airway breathing circulation. So for maintaining airway, there may be kinking of the neck. So we maintain a correct position. If the patient is breathing nicely, or if the patient is having labored breathing, we provide oxygen, and finally we'll look for the circulatory access. So the best option for this question will be maintain correct position and give oxygen. So this sums up our slides and the questions. So thank you so much.